While I make every effort to broadcast correct information, I'm also still learning. I will double check all my facts, but realize that healthcare is a constantly changing science and art. One doctor or healthcare provider may have a different way of doing things from another. I welcome any comments, suggestions, or correction of errors. I take no money from supplement or device companies. By listening to this podcast or reading this blog, you agree not to use this podcast or blog as medical advice or to treat any medical condition in either yourself or others, including but not limited to patients that you are treating. Consult your healthcare provider for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast or the website. Under no circumstances shall any guests or contributors to the podcast or blog or any employees, associates, or affiliates of the Boss Body podcast be responsible for damages arising from use of the podcast or the blog. This blog or podcast should not be used in any legal capacity whatsoever, including but not limited to establishing the standard of care in a legal sense or as a basis for expert witness testimony. No guarantee is given regarding the accuracy of any statements or opinions made on the podcast or the blog.
What's up, guys? It's Dr. Tim Jackson with another episode of the Boss Body Podcast. Thiamine, vitamin B1. It controls a lot of different functions in your body. Energy production. We're all looking for more energy. But also, in the past several years, our nervous systems have become increasingly dysregulated. So I'm personally, as a clinician, always searching for better ways to balance the autonomic nervous system. I kept coming across thiamine over and over and over again, but I'm a big believer in not reinventing the wheel. So I brought in someone who's a world-renowned expert and has published an entire book on thiamine. Welcome to the show, Dr. Chandler Marrs.
Oh, thank you for having me.
Absolutely. So your book, Thiamine Deficiency Disease, that came out in 2017 or 2016?
Correct.
And what inspired you and Dr. Lonsdale to publish this book?
Well, this is really Dr. Lonsdale's life's work, frankly. And he brought me on several years before that. We had met through my work on my website, Hormones Matter, and I had been doing work on Gardasil reactions in young women. And through a parent whose daughter had a reaction, I was introduced to Dr. Lonsdale. And ever since then, that was probably 2013, 2014, we had worked together, and he mentored me through thiamine and mitochondria. And a couple of years before the book, we wrote the book. He really wanted to write the book. I had a lot of life issues that I had to deal with, and finally I just said, okay, let's do it. And we did it, and I can't be more proud, grateful, everything that he persisted. And I think it turned out to be a really remarkable book.
Yeah, and so admittedly, I haven't had the chance to read it yet. It's on my list of, a million and one things to do. I'm going to go bankrupt if I buy all the books I want on Amazon and online in general. But thiamine, so what got you interested initially? I know you said your friend's daughter had an issue, but specifically, we know the B vitamins are all important, but what is so interesting about B1 or thiamine?
Well, thiamine's the king of all the B vitamins, if you will, or the queen, if that's your choice. But it really is the gatekeeper to everything else. And so if you are marginally insufficient, all the way to frankly deficient, but if you're even marginally insufficient in thiamine, everything else downstream of it is going to have a problem because it controls the enzymes that allow the substrates from our food to get into the mitochondria and eventually be converted into ATP. And so really, without enough thiamine, all of that food we eat, all of the macronutrients and all the other micronutrients can't get into that machinery to be processed. And so that's critically important. And I've always been interested in mitochondria But frankly, when I was in graduate school, I didn't give them much thought until I started working in medication adverse events and everything else. And my question was always, how can these different medications with entirely disparate mechanisms of action produce the same adverse effects? Well, because they damage the mitochondria by one mechanism or another, and then the mitochondria come back, since they are the energy producers and the pretty much the communication centers of our cells. The mitochondria control everything. Since when we damage those, you pretty much, all hell is unleashed on your body, because your body needs energy. Your body needs to be able to sense things and signal things, and it needs energy to do those things. And so when we break down that energy making capacity, we damage everything. And so that's one of the reasons that medications can have such disparate side effects in different people, because they're affecting mitochondria. And mitochondria affect everything else. And so depending upon your environment, your kind of the constellation of your totality of your diet, your exposures, everything else, it will express individually in that way, because all of that comes into play, but it still comes down to the mitochondria.
So yeah, I literally wrote down on a dry erase board one day, or one of those elongated dry erase boards, like all the disorders I could think of just off the top of my head. Like, what do they have in common? Mitochondrial dysfunction. And I've read, I mean, you correct me if I'm wrong, but roughly 35% of all medications damage the mitochondria.
Oh, all of them do. There's only 35% have been tested. There's probably more than that have been tested at this point. But when they do those testing, they're looking at specific mechanisms of damage, and they still have not looked at nutrient depletion, which also causes damage, because you need a variety of micronutrients to power the enzymes to get from point A to point B to ATP. And when you deplete that nutrient, that's where you have a log jam in the energy processing pathway. And so something has to be changed. Something has to be compensated for, and that's when you start getting other reactions. And so it's not just a nutrient depletion in the way that we tend to think about it, but it's integral to how we survive, because ATP is the base function for life. If you don't have ATP, you're dead. I mean, that's it. That's bottom line. It powers the way that we breathe. If we don't have ATP, we cannot use oxygen. We don't need an obstruction. We don't need, any of those other mechanisms, but you simply cannot incorporate oxygen into the mitochondria to turn it into more ATP. So essentially, ATP is life.
And so if I'm understanding you correctly, like the nutritional template or diet or nutrition paradigm we follow may not matter all that much if we are deficient in all the micronutrients, but especially B1.
Correct. Yes. And so you absolutely have to tackle B1. That doesn't mean you don't have to tackle everything else, but if you don't tackle B1, then you're not going to improve.
So let's talk about a medication that, I've had a lot of patients / clients have adverse reactions to, but fluoroquinolone antibiotics. I really, I mean, obviously, if you go into the emergency room and you either die or you risk your life with the fluoroquinolone, that's the only option, then would take the fluoroquinolone. But it seems like in almost every clinical scenario, there's a safer, equally efficacious option. So why are these mitochondrial poisons still out there?
Because they're easy and they're cost effective, at least on the front end for the pharmaceutical industry. They're not cost effective for the insurance agencies, but they don't seem to mind because of the reactions, that come after. But I think bottom line, they're cheap and they're easy. And we've always had the philosophy that more powerful is better. The biggest gun you can get is the one that you use to tackle disease. Well, that's not necessarily the right option, particularly when you're using antibiotics in general that kill not only whatever a bacteria that you're looking to kill, but everything else around it. And so I think it's just philosophically, that's what medicine has been trained to use the biggest, most powerful gun you can and obliterate things. and hope that the patient survives.
Yeah, and I think a lot of clinicians have forgotten about minimally effective dose.
Yes,
Don't go with the bare minimum. I was always taught, surgery is the last option. Anything with a high adverse event or risk profile, that's going to be, further upstream. We're going to start with the basics, but it seems like a lot of clinicians have forgotten that. And the thing that really gets me is, if a mom, like my sister, I have two nieces, so she would take them into, the traditional MD's office, and it was like antibiotic, antibiotic, antibiotic. Well, how do you know it's bacterial? Like, you haven't
exactly.
even done any testing. Like, in my experience, viral is more common than bacterial.
Exactly. Well, and how do you know that it isn't just a nutrient deficiency that is depressing the immune reaction and then is presenting with an infection, because you have this altered metabolism relative to a lack of vitamins and minerals, and often because of an abundance of processed foods. So, I think that is just, I see a lot of um, millennials and Gen Zers now, because they're getting old enough to deal with their own care. And they've been on medications, particularly the young men, since, early childhood. And as they've gotten older, they've become progressively more ill. And so part of their maturation process is learning how to take care of themselves and learning about what the damage that was done and how to recover that. And it's a hard, long battle to recover health after having been put on medications, whether they be psychotropic or repeated antibiotics or all of the above, for the first 15 years, 20 years of your life. But that's those generations are really struggling right now because of what we have done to them.
Yeah, absolutely. And I mean, one study I read, I think this was from 6 or 7 years ago, but the average umbilical cord of a newborn baby has between 250 to 300 known carcinogens.
Oh,
And
wow.
so we get vertical transmission.
Exactly.
People say, oh, well, I eat healthy, I eat organic. And I'm like, yes, so do I. I've been doing that since 2005. And unfortunately, yet it helps, but you still got to do other things. It's
Well,
not
yeah, you
just
got to avoid the medications. And there was just, there's a whole bunch of studies that recently came out again. I feel like it's rinse, ignore, repeat, regarding the effects of antidepressants in utero, when the pregnant mom is given antidepressants. And every time these studies come out, it's like some new finding. And in truth, this has been known since Prozac came out, and it's repeated over and over, and then denied, and then repeated, and then denied, and so it's this long cycle. And what is that? That was like in the 80s that the Prozac came out. And so, here we are 40 some odd years later, and we're still investigating the same things. And in reality, you don't even need to investigate. It doesn't need a double blind trial. All you need to know is understand the mechanisms and understand how things are transported, and you can hypothesize pretty accurately what's going to happen. But we don't like to do that.
right. Yeah, I tell people all the time because, the pushback that you get from the allopathic community, oh, well, there's studies on this. Okay, well, if A causes B and B causes C, we can say A causes C. We don't need to spend, $3
Yeah,
billion on a study for that.
yeah.
But with thiamine, I know you can't just, if you've been deficient or insufficient for a number of years, you can't just start popping high doses. But let's talk about not specific recommendations to people, but just in general dosing for adults, and the different forms of thiamine also.
Okay, well, let's even back it up a little further and talk about what the RDA is and what it means. So the RDA for thiamine for adults is like 1.3 and 1.4 milligrams, which is absolutely nothing. Now, because we fortify our junk foods, most people get about 6 milligrams a day. So in theory, no one should be thiamine deficient. But then you have to go back and look at what thiamine does and how it does it, and what are the detractors to thiamine, the blockages, the antagonists of thiamine. Well, everything in the current modern diet pretty much blocks thiamine by a mechanism or another. So soybean oil, for example, activates or upregulates an enzyme called, well, doesn't matter, pyruvate dehydrogenase kinase, tongue twister, that then downregulates pyruvate dehydrogenase. And that's the big gatekeeper enzyme that thiamine is involved in. It's involved in several other enzymes, but that's the one of the main ones. And so every time you eat a product with soybean oil, you're telling that gatekeeper to stay closed. Okay. And every processed food now, every food has soybean oil in. So there's one detractor. All of the sugars and the high fructose corn syrups and everything else that we eat, every time you eat a glucose, sucrose dense food, there's multiple pathways, but essentially it ends up taking more energy to process than it actually makes. And that's all dependent upon thiamine. So if you're eating a lot of sugary foods, you better have quite a bit of extra thiamine in there. And so there was a study a while back of I'm going to put this in air quotes, healthy subjects that they gave varying degrees of carbohydrates in their diets. And when the diet was at 55% carbohydrate, which a lot of people, that's normal, it started declining. Their thiamine started declining, and it started declining significantly as it went up. And so you see, and that was no other variable other than just increasing the density of carbohydrates in diet. So you've got to take that. Every medication known to man, as I said, damages the mitochondria. I know that they don't agree with it, but it does by one mechanism or another. So that's going to increase your need for thiamine. There are a lot of medications that specifically block thiamine. There's a long list of them. Metformin is one of them because it blocks the thiamine transporter. And so if you're taking metformin, then your transporters are downregulated. And so you're not going to be getting enough thiamine. So on the one hand, you have studies that say, oh, we only need 1 milligram essentially of thiamine, which this was the bare minimum to have you not die. And the other hand, NIH says, well, everybody's getting about 6, so nobody is deficient. And so you have this notion that it's rare, and it's not. So that's something we have to consider, is that it's not rare. And the symptoms that we can discuss this later, the symptoms that they present with that are often in contradiction to the classical symptoms that everybody's been taught about thiamine, because those are very late stage and those are very specific. It takes years to get to that. So all of that being said, how much thiamine do you really need? Well, you need enough so that you can support the function of daily living. And how much is that? It entirely depends on you and what your status of health is, and how, your threats to your health are, your stress. So if someone has been deficient, whether it is frank deficiency or functionally deficient, or has had chronic illness for a period of time, because anyone with chronic illness, the inability to heal means essentially you don't have the energy to heal. So anyone that is going to be thiamine insufficient all the way to frankly deficient. So how do you replete those nutrients? Well, there are 2 methods that you can do, and it depends on the severity of your deficiency, and it depends upon the care that you have and the assistance that you have. If you have a physician that knows how to do this and knows how to manage electrolytes and knows how to address the other deficiencies and can manage this whole process, then you can go high dose pretty quickly. And you can manage things along the way. And IV or IM would be best. But if you are doing this on your own and you have to navigate this and you're already ill, then the safest way to do this is to start at a low dose and titrate up gradually in a kind of stair-step fashion over a period of time, so that at each increase, you give your body a chance to adapt to its new state. So think of it like a opposite of a withdrawal syndrome, where, you know, all of these things that unwound and rewound because of your deficiency now have to turn back on and, you know, do their job correctly. And there are a lot of hiccups in that process. So you start at a low dose and you gradually increase it until you find your effective dose. Now, what is that effective dose and what is that low dose? Again, incredibly individual. I have some people that have to start at like microdoses, sprinkles of thiamine, or lest they get a big histamine or other reaction, because their bodies are so sensitive and deprived. Now, often these people are severely deficient in thiamine, but because no one will treat them, they have to manage this on their own. So they do the best they can. They start with maybe a single milligram, and they increase very gradually over an extended period of time, giving their body a chance to adapt to each time. And this could take months to a year. And so it's not ideal, and it's definitely very hard work, but that's what you got to do, because most physicians won't treat them. Now, other people can withstand a little bit more. So they may start with something like 100 milligrams of thiamine hydrochloride. And that's still considered a low dose in this world, but it's a much higher dose than a single milligram. So, you know, they'll start with 100 milligrams, and then, you know, a couple weeks later, they'll maybe either add 50 or another 100, and so on and so forth, until they get to a dose. Now, the doses with hydrochloride range anywhere from 500 to 2,000 milligrams, 2 grams, because hydrochloride is less potent than the other forms that I'm going to mention here. And it requires transporters. And so if you have a genetic defect in the transporters, and or you're taking medications, and or you've got something else going on that are going to affect your ability to transport thiamine, the thiamine hydrochloride is going to not be as effective for you until you reach a higher dose. Okay, but it may cause reactions in you at a much lower dose. So you've got that wiggle room you have to play with. So the other forms of thiamine are TTFD, tetrahydroforfuryl. Can never say that. Comes in a couple brand names: allithiamine, lipothiamine, and Thiamax. Allithiamine and lipothiamine are 50 milligrams. Thiamax is 100 milligrams, unless he's changed and offered a 50 milligram. Thiamax is the cleanest of them all, meaning it has the fewest, it has no preservatives, additives, or anything like that. And it's a much smaller capsule, hence. And so it works really good for those who can't swallow well, but it comes at 100 milligrams. And so that may be too much for someone to start with, whereas the allithiamine and the lipothiamine come at 50 milligrams. The lipothiamine also contains alpha lipoic acid, which is also needed, a small amount, at the pyruvate dehydrogenase enzyme, that top enzyme. And so it's good for that, and it's a teeny little caplet. So I do like lipothiamine. Allithiamine I've used too, but you know, it does have additives that I would rather it not have. But those are the 3 TTFD versions, and those are more potent because the chemistry of it's a synthetic thiamine. They call it fat soluble. It's not technically fat soluble, but the way it interacts with the cell wall, it can transfer, and then it loses an end to it, and then it becomes active once it gets inside. So it doesn't need a transporter. And so it is much more potent. Now, the problem—
Which one doesn't require transporter?
The TTFD brands.
Right. Okay.
Amphothymine, which we're going to talk about next, also doesn't require a transporter. It's a different molecule than the TTFDs. So, so that makes those 2 or those 4 much more potent, which could be good and it could be bad, depending upon what your body can handle. Now, both bempho and benfotiamine, which we haven't talked about yet, but it is also a synthetic molecule. It crosses the cell barrier by a different mechanism. It's a different molecule than the other 3. But it is equally potent. However, there's quite a bit of debate as to whether it crosses the blood-brain barrier. In studies of animals, they have indicated that there are no molecules of bempo or its derivatives in the brain. So, however, it is used regularly in a variety of conditions of which the nervous system is involved. So, while it may or may not cross the brain, we know that the brain does kind of protect its thiamine stores. So you will dissipate peripheral stores before you will dissipate nervous system stores. So by repleting the peripheral system, you may actually just provide enough for the brain to function. So I don't know. There's big debate on that. People swear by it. There's Alzheimer's studies that say that they've improved with bempo and TTFD, both of them. So I don't know. So either one of those is good, but they are more potent. Because they're more potent, they tend to require a smaller dose. And a lot of people can get by with, 150 to 300 milligrams of either of those forms. Whereas, as I said, you need a good 1,500 to 2,000 of the hydrochloride. So it's pros and cons. Some will go high doses in the other too. So that doesn't, there's no one thing that says if you're not getting better at 300 that 400 won't make you better. The opposite is also true. If you are getting better at 300, 400 might not necessarily improve things anymore. There's a more art to this than science in a lot of cases, because it's very individual. And based upon what you need. So yeah, so it's a little bit difficult to navigate this, especially for the layperson. That's why I recommend reading up as much as you can. Read the book if you can. Read the articles on HM, Hormones Matter, YouTube videos, etc. Learn about the experience. The case stories on HM are particularly illustrative for patients about to go through this, because they demonstrate the difficulties that individuals may have, the kind of increasing, decreasing of symptoms, and the trajectory of the healing process. It's not something you can take like an antibiotic for 10 days and be fine. It's a much longer process.
Going back to the TTFD, why would someone? So you said there's 3 different brands of TTFD.
Correct.
Lipothiamine,
lipothiamine, and Thimax. Different companies.
Why would someone, if you need to get into the central nervous system, what is the benefit of bempotiamine over the TTFD?
Well, I think the TTFD is better than the bempo for the CNS, frankly. However, people who produce bempo would disagree. But there's a long list of science, particularly in Japan, where TTFD was originated, decades and decades, showing that it is bioactive in the brain, whereas bempo has been indicated that it's not. The caveat, of course, is bempo is used a lot more frequently in the US, and so there are more studies here published highlighting the successes of bempotiamine.
And for people who may not know about the issue with glutathione, I was reading on your website. I'm a big glutathione guy.
Yeah.
If you're already deficient, if your RBC, red blood cell glutathione levels are low, do you need to take either selenium or S-acetylglutathione before you start repleting your thiamine levels?
Or even sulfur, so Molly, I could never say that.
Molybdenum?
Yes. Molly, but that's a drug. So no, I can't say that. Yes, possibly. But you also may need to start with thiamine hydrochloride if you're already low, because that'll help put things back in order. So it does take energy to detox. And if you're deficient in energy because of altered mitochondrial function and pathways, then I feel as though you need to tackle the energy pathways the best you can before going full bore on the detox.
Absolutely. And You mentioned earlier electrolytes. So,
Yes,
I mean, I think there's an epidemic of potassium deficiency,
exactly.
and on
And
top of that,
calcium deficiency and salt deficiency and phosphorus deficiency and and magnesium deficiency. So I mean all of them, everybody is deficient in everything. So let's go through them kind of one by one. Magnesium deficiency is endemic in the US, probably worldwide. Data ranges from like 60 to 80% of the population is not getting RDA. Now we know RDA values are bare minimum to survive. So if that many people are not getting RDA, there's a real problem. And so magnesium, with regard to thiamine, magnesium, in addition to all the things it does, is necessary to activate the thiamine. And so if you don't have magnesium, you're going to have a problem getting your thiamine under control. Now, the problem with magnesium is a lot of people like to do high dosing magnesium. And they're not sufficient in thiamine. And there's a feedback mechanism with another enzyme down in the chain that if you're getting too much magnesium and you don't have enough thiamine, it'll slow down the pyruvate enzyme, the pyruvate dehydrogenase enzyme. So it actually could kick people into a deficiency state, kind of through a back door, if you will. So I always recommend that you got to get your thiamine going, but start again with your magnesium at a lower dose. I am not a fan of, even once thiamine is going, of huge doses of magnesium, because I don't think you just don't need them. I mean, there are instances where perhaps you're using magnesium to decrease blood pressure for an acute attack, or in preeclampsia you can use it, or in preterm labor they use it for, and that's useful for an acute attack, but that's not something you sustain over a time. So magnesium, kind of parallel it with your thiamine. However, track your diet. I like the app Chronometer because it does track micronutrients. I think most people are shocked by how few micronutrients in general they get. So if you track your diet for a few days to see what your averages that'll give you an idea of where you're likely lacking, because there are some inaccuracies in it, but it gives you a picture. So magnesium, potassium, hugely deficient potassium, just about everybody. And I think particularly if you have heart-related issues, you need to get 35 to 4,500 milligrams of potassium. And if you're going to go high dose thiamine, you absolutely need those. And so the thiamine will kick things into gear and start bringing the potassium into the cell, as opposed to it kind of floating around. And so it'll appear as though you're making yourself potassium deficient, when in truth you're just using potassium, but it'll feel like you're becoming deficient to some extent. And so you really need to track the potassium, particularly with thiamine. B12 is another one. If you're doing high dose B12, you better have your potassium online, or else you're going to have some weird side effects. And I recommend, again, track on Chronometer and try to get as much as you can in through diet. And if you need to do an electrolyte drink or something like that, go for it. But read the ingredients and the balance of electrolytes, because they're all over the place depending upon who manufactures it.
what are some of the symptoms? You said B1 or replenishing or repleting thiamine can make you feel like you're potassium deficient, when in fact you're just using it up. What are some of the
You get kind of dizziness, weakness. You may get heart palpitations, which is also related to calcium, which we'll talk about next. But yeah, you just start to feel, you crash. Basically, that's it. You crash. Everything is worse.
Gotcha.
So
Absolutely.
and so the other one that folks are deficient in, is because nobody eats dairy anymore, is calcium. And because AMA has told you that we shouldn't eat calcium, or supplement calcium, because a calcification of arteries, which is an entirely different mechanism. So everybody's deficient in calcium. And so calcium is critically important to managing the activity of cells, and mitochondria have to manage it with the endoplasmic reticulum, and they talk back and forth. And when you all of a sudden start taking thiamine, the calcium stores have to be managed appropriately. Otherwise, you get this kind of flood in one place where it shouldn't be and not in another place. And you get very intense heart palpitations and reactions relative to the function of the heart, which can be scary, very scary. You can also get some in the brain, like brain zaps and so on and so forth. And I figured this out just because I couldn't figure out why all these people were having these reactions, and started mapping it. And I found out that it was calcium, mapped it all the way through the different mechanisms, and then realized that if you gave people a Cal Mag supplement, calcium mag, and I like the 2-to-1 ratio, so more calcium than magnesium, that all of those symptoms dissipated. And they didn't have the heart-related symptoms relative to thiamine repletion, which is wonderful. And so in mapping the mechanisms, my thought is that it is basically because we're all deficient in it. And
So
again,
if you start replenishing B1 and you don't have enough calcium, it may make you deficient. It may induce
but you may be deficient already, and you may have your body may have adapted to that deficiency by re-regulating how calcium is managed. And when you start turning things on again, it doesn't have enough calcium to regulate it appropriately. And so it's kind of overshot here and undershot there, and it changes the rhythm of your heart, frankly, because that's so incredibly dependent. And it's such a simple thing to do, is to supplement with a Cal Mag.
So let's talk about the I know a lot of people are listening to this and they're cringing because they've heard, Morley Robbins and the root cause protocol and the magnesium and, never take calcium without vitamin K2. You mentioned there were 2 different mechanisms. Can you touch on those?
2 different mechanisms of what?
For the calcification of the arteries and intracellular calcium signaling.
Oh yeah, that's a really complicated pathway. Can we skip that one? I have written a couple articles on it. If you want it, on hormones matter. There's actually 3 articles. One was just beginning because of COVID. They had indicated that calcium tsunami was how they described the COVID heart damage. And that's what triggered my investigation into calcium, to figure out why that was happening. And it mirrored what people were describing in their repletion. And so I did map the mechanisms, but it's
you're still a fan of the 2-to-1 ratio of calcium and magnesium?
For most people, that seems to work. Now, if you have absolutely no calcium in your diet, you may have to have additional calcium supplementation separately, because that only provides like 1/3 of the RDA. And the RDA, remember, is very low. And so you may need even more, but that seems to dissipate the symptoms.
All right. And so we did we do phosphorus or fluoride?
No, we haven't done phosphorus, which is mostly protein. I mean, you get it mostly from protein in your diet, and people who are vegetarian and or women who have been told not to eat protein for whatever asinine reason are typically low in phosphorus. And the reason you need phosphorus is you need phosphates, which is what you get from the phosphorus, to donate to the free thiamine so that it can become activated. So in order for thiamine to be activated, it needs to be phosphorylated. And there's a couple different forms. There's where you get 1, 2, or 3 phosphates attached to it. The one with 2 is the one that's active, the most active. The other 2 are like 10% of the thiamine activity. But if you're low in phosphorus, you're not going to phosphorylate. And there's phosphorylation reactions are throughout the entire body. So it's not just going to affect thiamine, it's going to affect a whole bunch of other stuff. So, you really got to pay attention to that. And the other one is salt. We've been told for decades to do low salt and eat more carbs. And that's absolutely opposite of what we need to do. And particularly, again, with individuals with heart-related symptoms, they need the salt, particularly the POTS, the orthostatic
tachycardia
syndrome. Yeah, all these tongue twisters. Yeah, that's semi-common knowledge that they need salt. more salt to manage that, but not as common as it should be. And again, when you start increasing the energy pathways and upregulating everything and providing the cells with the energies they need to function normally or more properly, things that weren't necessarily identified as deficient because everything was down regulated as a compensatory reaction are now going to become deficient. And so you need to increase your salt intake.
And so with, obviously, the book is about thiamine, but let's talk about some of the other B vitamins, especially B2, riboflavin, and how that fits in with B1 and when it should be introduced.
So whenever you are supplementing thiamine, you're likely going to need the other B vitamins, and you're likely going to uncover latent deficiencies. Which ones? Who knows? Now, riboflavin in particular, because it is a required cofactor in that pyruvate enzyme, along with thiamine and along with alpha lipoic acid, typically is needed very early on. Now, in some people, they need high doses of riboflavin because they're obviously deficient in riboflavin in addition to thiamine. And so if they don't supplement the riboflavin, they will experience what's called air hunger. Now, thiamine itself can cause air hunger. Riboflavin also causes air hunger. And that's air hunger is basically the inability to use the molecular oxygen is what's happening underneath everything. But it's a sensation that you're not breathing right. But there's no markers of it. You take your O2 sats, they're fine. They do the x-rays of the lungs and everything else, everything's fine. It's just a sensation when in reality what's happening is you're not using the oxygen very well. And so you need riboflavin. Now, dosing on riboflavin, again, is highly varied. It can be anything from a few milligrams to several hundred milligrams. Some people think they need a 1-to-1 with thiamine, some people 2-to-1 or 1-to-2. So you just got to play. There's a lot of trial and error. I wish there was not trial and error. I wish we could do constant testing and see what was going on. But we can't even get people to get tested for thiamine. So it's difficult to get anything else. Every now and again, you'll get a full oats test and you'll see, you'll have kind of indication of what's going on. But again, that's a point in time. It all changes as soon as you start supplementing something. So
let's talk about the best test for thiamine. Is there an RBC thiamine? I order organic acids testing, and the lab that I use or typically use, they don't have thiamine on there. They have B2 through B12.
Oh, really? Yeah, see, part of the problem is we don't recognize thiamine as being important. Everybody suspects that we solve that problem with fortification and enrichment, and therefore there's no reason to test. Only if you're an alcoholic and have been an alcoholic for 50 years and stumbling around, that's when we might test thiamine if you're lucky. But no, they don't test it. So well, the best test, I believe, is the erythrocyte transketolase activation test. And there's no real labs that do that. There's one in New Jersey that does part of it. I have it listed. There's an article on the website called Understanding the Labs or something like that. And it lists the few labs that do this. There's a couple in Europe that do it. But it's not really well known. There was a lab in Milwaukee that was developing one, and hopefully they do because they'd be, they'd have quite a big market for it, but so far it hasn't come to fruition. So that's your best test, but it's not available anymore because they have supplanted it with just the easy, either the plasma or the serum tests. You can get it. Which are highly inaccurate with a high false negative. And then they have the whole blood one, which is a little bit better, but it's not always available and it's more expensive. So it's very difficult. The bottom line is it's very difficult. And it's often people are left to treat symptomatically.
So what do you see as the most important nutrients outside of micronutrients that will help the assimilation of thiamine.
Outside of vitamins and minerals?
Yeah, like
So
amino
that's
acids. Yeah,
Oh, okay,
fatty
okay,
acids,
like
amino
fats,
acids.
yeah, well, I think a good solid whole food diet is important, fat is, though fat does require thiamine, and that pathway requires thiamine too. The fat pathway, will net you about 100 ATP or more per molecule of fat, whereas the glucose pathway will net you, maybe 30. So if you can metabolize fat, uh, and some people can't, because we've so screwed up our metabolism, but if you can metabolize fat, I would, increase your consumption of good fats, not
Trans
the heavy
fats.
oils, yeah,
Right.
but coconut or meat fat, protein, that kind of thing. And I would obviously reduce my consumption of processed foods, if not eliminate it completely, because those carry with them uh, too many toxicants, and you end up it costing the body more to process than they provide.
Absolutely. Let's talk about thiamine and athletic performance and the importance also of thiamine for balancing the autonomic nervous system. So people with anxiety or mood issues, can that be related to
Oh,
thiamine?
absolutely, because the brain needs so much energy. And if the brain is not getting energy, then, all sorts of symptoms arise from that. And even the most basic, again, autonomic function, brainstem function, hugely energy dependent. And so if the brain is not getting sufficient ATP, then those processes that are normally automatic and very well regulated become less automatic and less well regulated, and you get spurts of this and spurts of that, which is essentially like little bursts of energy where things start firing really good, and then it downregulates, and then there's nothing, and so it's completely too much, too little, too soon, all of
Right.
that. It's just that dysregulation. And so if you've got autonomic dysregulation of any sort, I would go to thiamine and start looking at thiamine and other nutrients, but go start feeding your body what it needs to produce energy, because it obviously does not have enough to manage the automatic functions that it usually just hangs out in the background.
Absolutely. And then I know you said the more glucose we consume, the more it depletes thiamine. But also, anytime our nervous system is stressed, that also
Exactly. Yeah.
depletes thiamine.
Well, yeah,
So
so any life is stressful. Like that life is stress, and it requires energy, and you want to have the energy to meet those stressors and survive those stressors. So yes, if you have an incredibly stressful existence, then you probably need a little bit more help in that area than other people that don't have as much stress. And that goes to athletes, because athletes, while they love what they do, that's a lot of stress on the body.
yeah,
And that's often a lot of carbohydrates that are required to power that. In addition, so they need to up their thiamine to continue to function at that high level.
absolutely. So what's one thing that you know today that you wish you would have known 10 to 12 years ago?
Oh, I wish I would have known all of this, frankly, because I had, going back to way back, had a difficult pregnancy, preterm labor, preeclampsia, all of those things, likely nutrient deficiencies, looking back on all of that, but I didn't know any of this. So I would have loved to have known that. I probably would have made, my kids are healthy now, but I would have made healthier kids then too. So, you know,
Absolutely. Well, I'm sure people are going to listen to this, and if they're trying to conceive or they've already conceived, they're going to be looking at their micronutrient status, and I think that's
oh,
a
I hope so. I hope so. When I used to, I haven't in a while, but I used to do a lot of talks for midwives and GYN, OBGYNs and around pregnancy and parturition and such. And one of the things I've always tried to stress is that you've got to give yourself a chance to get healthy before you try to conceive. Both mom and dad. Usually we focus on the mom, but both parents have to be healthy. And I say in reality, you should give yourself a year before you try to conceive and clean everything up and then go for it. But we don't like that. We like things now. But if you've been down that route where you're having difficulty conceiving, take time off and each of you get healthy before trying again. It's not going to get any better with infertility treatments. You're going to still have the same issue you had before. It's just going to force a pregnancy when that may not be what you really want.
And if you increase cellular ATP and start dumping toxins when you're pregnant, that's not a good thing. So we want to detox mom, obviously,
You want to be as healthy as possible, both partners, but don't forget dad. Dad contributes to this. And,
Yes.
we tend to give dad a pass on this. And 50% of those genes are his.
I remember, I think the study came out last year or the year before showing that, how back in the day we learned that mitochondrial DNA came from mom, but newer research is showing that dad's DNA plays a role to a degree.
Oh, dad's DNA play most of it. So DNA in general, so mitochondrial DNA is mostly mom, but the functioning of the mitochondria is mom and dad equally, because all of the genes that do all of the housekeeping and everything else come from regular old DNA. So mom and dad have a huge role in how the mitochondria function. It's just not relative to the small composition of mitochondrial disease. It's nuclear DNA. And so dad most definitely has to have his house in order if you're going to have a healthy child.
Absolutely. Well, thank you so much for the work that you're doing. We're going to put up all your links to your website and Facebook group. Can you mention that real quick?
Oh yeah, we have a private Facebook group called I can't even speak today. Understanding Mitochondrial Nutrients. And so you're welcome to join that. Hormones Matter is the website. And the other thing I do that we didn't talk about, the athlete part, I'm old, I lift, so I have a group of called Old Ladies Lift. That's also a private Facebook group and a website of the same name.
Awesome. Well, we'll put all of that up. Thanks for coming on the show, and hopefully we can have you back on again in the future.
Oh, you're welcome.
Thank you so much.